Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining us today, we have our clinical chief, Nick Smith.
Good afternoon.
And our assistant medical director, Dr. Mike DePasquale.
How are we doing?
Today, we're going to tackle a tried and true exam, data point, vital sign even, that's drilled into many of your heads since early on in paramedic school. And we may even take a shot at the sacred cow, the orthostatic vital sign. These are the holy grail of volume assessment. They're not to be missed. We're tested over these things. And honestly, not paramedics or paramedic school. These are a part of emergency medicine training and kind of classic med school training as well. So today we're going to discuss a little bit of data, not drown everybody in data, but talk about some of the data that exists for orthostatic vitals and their usage and their utility. Also going to talk about some data that doesn't exist that may cast doubt on whether or not we should use them, talk some specifics about what we want going forward here at MCHD, and really end up, I believe, with the story ending with these should probably stay at best in the emergency department and the hospital. So not to try to spoil the ending too much, but let's go back to the beginning, Nick, and talk to the listeners about how these were taught in paramedic school.
Yeah, so back when orthostatic vital signs were still very much being taught as, like you said, a gold standard for being a diagnostic key to volume loss in patients with syncope, near syncope, reports of lightheadedness or dizziness. And I remember that the big teaching point there was the 10-20-30 rule. So if you had a 10-point drop in diastolic blood pressure, a 20-point drop in systolic blood pressure, or a 30-point increase in your pulse change after you have that patient go from a supine to a sitting or sitting to standing position with 3 minutes in between, you had an orthostatic positive sign for volume loss. You want to talk a little bit about, sort of the holes in this and also maybe a little bit of background about the ortho positivity and why that has been taught sort of as this must do in EMS?
Yeah, and let's just think about the way you just described that. Supine to sitting, sitting to standing with 3 minutes in between, some even longer depending on where you look. Who's setting their clock and taking 3 minutes? We don't take 3 minutes to do anything. Now, to be fair, before we go into the holes, there is some data out there. If you look at pro-orthostatic vital sign collection articles or sources or even in textbooks, you'll see that there was a study by Cohen et al. In 2006 in the journal Blood Pressure. I've never read the journal Blood Pressure before, but Cohen's group found that orthostatic positive patients in the hospital had increased mortality. So if we look for these patients and we find them, we're going to find the ones that are at highest risk. That's what we want to do. That's not necessarily a bad thing, but there's better data than exists that really can punch some holes into the Cohen paper, and that is to really just get all the way down to the base. Elderly patients especially have orthostatic vital signs that are positive with no symptoms a significant amount of the time. In other words, you could go into any extended care facility, assisted living, nursing home, and find a kind, gentle grandmother or grandfather and take them from supine to sitting up, and they will have one of those 10, 20, or 30 changes. So if that's the case, what information does that really give us? The rate of orthostatic hypotension in nursing home patients at baseline is somewhere around 50%. It's not a few in the dining hall. That's half of the people eating their lunch. Baseline for those over 70, so not nursing home, these are healthy, living alone, independent folks, 70 and older, a third of those patients will be orthostatic positive at baseline. No complaints. Teens, it's not just the elderlies. Teenagers are often orthostatic with no symptoms. This can vary based on the time of day. It's not constant throughout, 24-hour period. And then when we think about our elderly patients, One of our more common medications that we see in EMS, we see for blood pressure control, for atrial fibrillation rate control is our beta blockers, for example. These can play a huge role in whether or not you're going to actually be orthostatic positive or not. So if you're looking for a positive sign in a patient and they're on metoprolol or carvedilol or insert any nodal blocker, they may not mount that response. So then you're going to have an orthostatic negative patient that's just negative because the drug they were on. So one of the biggest studies that supports this was done by White in 2019. They saw no change in 30-day adverse events if their orthostatic vital signs were positive. So lots of people at baseline, teenagers, elderly patients, 70 and older, will have orthostatic positive vital signs just in Target, in Cane's, eating their chicken for lunch, whatever it is they're doing. They're going to be orthostatic positive. So what value does that test really have? And I would say it doesn't have a whole lot of value, but someone's going to say from the back of the room, the AHA, they like orthostatic vital signs. It's in the Syncope guidelines. And it is, they are. But Syncope guidelines aren't written for EMS, number one. And number two, AHA guidelines are just that. They're guidelines. They're not written in stone tablets. They didn't come from up on the mountain. Think about all of the ACLS guidelines that we've rigged to take care of patients that aren't ACS patients, that aren't cardiac ischemic patients that have cardiac arrest. Think about our approach to hyperkalemia here at MCHD. That's not really anywhere to be found in any AHA guideline, but we know those patients exist. So yes, it's in the AHA Syncope guidelines. Yes, that's worth mentioning, but those don't apply to EMS. And again, those are just guidelines. There's some other problems with utilizing these orthostatic vitals, and one of the big ones is something called premature closure, and that relates to incorporation bias. I'm going to let Dr. DePasquale explain what those two things mean and how these can really burn us if we put too much weight in them.
Yeah, for sure. I mean, you talk a lot about kind of how orthostatic vital signs might fall short in certain populations, but I can hear people asking already, okay, if that's the case, what's the downside, right? It's just another data point. It's just something else that we can do. And if it's positive, we have to review that in kind of the context of the patient that we're looking at. But what's the harm here? And I think talking about premature closure and incorporation bias is a good point. Premature closure being, of course, where you've kind of come to a conclusion of what the diagnosis is too early, and kind of hang your hat on that and say, okay, we're done here, right? Premature closure. So I think a good way to kind of talk about this is to kind of give a little case example. So consider a case where you have someone who calls EMS with near syncope. You get there and they look okay, blood pressure might be a little bit low, and they're telling you about how they've had this diarrhea off and on for a couple of days. And so you get vital signs, you get a 12 lead, you do the orthostatics on them, and of course it's positive. You think, okay, well, this guy's had some diarrhea and his blood pressure is a little soft and he's got positive orthostatics. He's probably just dehydrated. Patient says, I really don't feel like going to the hospital. I'm not vomiting. I just have diarrhea. I'll just stay home, drink some Gatorades, and I'll feel fine. And that seems like a reasonable solution. And so the patient signs off and you go back in service. But the real issue there is that not only were they mildly dehydrated from their diarrhea, but EKG could show something like QTC prolongation. They could be hypokalemic, hypomagnesiemic, have some other electrolyte derangement that would put them at risk for cardiac arrhythmia and sudden cardiac death. That, of course, we kind of wrote off early because they were orthostatic and just kind of chalked it up to them being dehydrated. But there's a lot more to it than that, and I think that is somewhat of a pitfall of doing these orthostatics, in that you can get this kind of false sense of security in knowing that, oh, I think they're just dehydrated. That's probably the cause here. And that leads to that kind of premature closure that could potentially harm some people. So I think that's a real potential risk of doing this. Not to mention the time it takes to do it properly, right? I mean, 10 minutes on scene doing orthostatics, I could tell no one's doing that, right? Having been a medic myself, I've guilty as charged as doing orthostatics. We were all taught this, and it was just get a blood pressure, stand them up, what's the blood pressure immediately, right? And it's lower. It's always lower, right? Everyone's blood pressure goes down when they stand up. You have to re-equilibrate, which is why you're supposed to wait, and I don't think anyone's doing that. I mean, we probably don't even do it in the hospital either. When you get nurses, stand them up and boom, get the next blood pressure, So, because no one has 10 minutes to sit there and do the whole proper thing. So, but anyway, that's another reason why I think that there is definitely potential harm in doing this in the EMS field.
If you think orthostatic positive, you stop thinking. It's easy to just move on to, drink some Gatorade. And it's not that we would discharge that patient. We're not discharging a patient in EMS. It's just a matter of how much information you give that patient and how good you make them feel or not good about their decision to refuse. And in this situation, we would say something like, I know you're lightheaded, I know you've got diarrhea, and you may just be mildly dehydrated, but your electrolytes could be way off. We've seen that before, and the hospital is the only place that can check that. So it's more about the presentation of the risks and the benefits to the patient. And they may still say, I want to stay home. And if that's the case, so be it. We just want to be on the firm side of patient advocacy and giving them correct medical information. What about training, Nick?
Yeah, so this is not something we train on. I think both of you hit on a really good point about the risk for the patient and the potential for that premature closure bias. That same patient that calls us when they go from supine to standing, they have a full syncopal episode, fall, hip fracture. We very much have similar risks when we're doing that with our patients who call us and they have dizziness or lightheadedness or a prior syncope or near syncope, and we're out there dealing with them and taking care of them. We don't want to put them in a bad situation that could harm them even further. So it is absolutely not something that is covered in our training here at MCHD. We don't have a protocol for checking orthostatic vital signs. And really, why perform a risky test that ultimately is not going to change our management of the patient? If you have a lightheaded syncope, near syncope patient, they're not ambulating to the ambulance. We're gonna take care of them. We're gonna bring the stretcher close. We're still gonna perform the same treatment plan and pattern that we would have without these orthostatics. So why take the risk unnecessarily for something that's just going to put the patient potentially in a much worse situation than we found them?
And we've seen this, and we've seen this in chart review. This is something that we've cringed when we read these charts, and then we realize, hey, we've not really talked about this from an evidence expectation standpoint. So that's one of the reasons why we're having the podcast today. Take the worst case scenario, Dr. DePasquale. There's some times, and I've seen this in the hospital, where well-meaning folks go to do orthostatics and really end up into trouble.
Sure. This is EMS, right? So we like to do stuff. We have somewhat of a limited amount of things that we can do in the toolbox, right? Because we can't get labs and do all that other stuff. So any kind of data point or something that we can add to it, people like to do. So I get the thinking here, but I agree. Sometimes we do cringe with the chart reviews on some of these. So here's an example, right? So somebody who is maybe 65 years old and is having several days of dark and tarry stool, who calls because they're dizzy and lightheaded, right? Think, what is that, right? Dark and tarry stool, you get to them and their blood pressure is soft. I don't think you need to stand them up to kind of get to what the answer is here. They've been weak for a couple of days. They're mildly tachycardic, mildly hypotensive, right? That's a GI bleed, right? There's no need to stand them up. They're going to be, or even if they're not going to be, orthostatic positive. It changes nothing. That patient needs to go. They need to have blood work. They need to see what their hemoglobin is. They might need a blood transfusion. They need to have more investigation as to what's bleeding, right? So why go through the process of standing that person up and getting a repeat blood pressure just for the potential for them to pass out or feel worse, when it doesn't change what we do and it could potentially add harm? So in that respect, I don't think there's any utility in doing the exam because you gain nothing and stand to put the patient at potential risk. So,
and I think we can be as clear as we want to be here. This is not a test, an exam, a data point that we want our MCHD listeners performing.
Right.
Very, very clear period at the end of the sentence. No real ifs, ands, or buts. If you feel like you have a patient that would benefit from orthostatic vital signs, let's talk offline. Shoot me an email. Come by the office. We'll discuss it. But in the end, it's not going to change our management. Is it a huge risk we're putting the patients in? I don't want to overstate it.
Right.
We're not going to have a rash of hip fractures, but we might have one, and that's one too many. In this GI bleed patient, and we've seen charts like this, we've done orthostatics and end up giving fluids to rescue, God forbid, push dose pressors to rescue low blood pressures when we should have just transferred the patient to the stretcher by not standing them in the end. There's no EMS evidence. I did a PubMed search real quick, EMS and orthostatic vitals, pre-hospital and orthostatic vitals, and I got nothing. So if you have some blazing evidence out there that I missed, please hit the podcast email. But
Yeah.
I did a quick look, and I got zero, zilch, nada. So
Not a lot of hits on Up to Date either, so I
nothing.
think we're covered.
All right, we're good. We didn't go deep, but that's a mid dive for sure. I want to close and just not be a hypocrite. There are patients in the emergency department. I know our medics are in and out when I'm working, and I'm sure there's a point or a time where somebody's seen me perform some pseudo orthostatic vital signs without a 3-minute wait in between. There are times where when the decision is discharge or admit, and I can collect that data point and use that to convince maybe a hospitalist or an intensivist or a cardiologist or insert the admitting physician that the patient is sick enough to be admitted. I have done that before. That's happened. So, yeah, I also do them knowing that if it's negative, I'm going to pocket that and not tell anyone because they're just as likely to be negative in a patient who does have true volume loss. So, yeah, stability for discharge, need for admission. Sometimes we go searching and say things like, oh, the nitro made the chest pain better, Dr. Hospitalist. And we know that the nitro can also make the esophageal spasm better, and that really shouldn't be a predictor or a data point. But you do what you have to do to get by. But I'm also doing it in a hospital setting with help, with the patient very carefully supported, not in a trailer or a hoarder house or a small space where there's trip hazards and all the other things that you have out in the field that are much more difficult than what I have in the ED. And in the end, we're not discharging patients in the EMS system. So it's really an entirely different decision tree. But I don't want to be a total hypocrite. I've got some shifts this week, and if I go out there and check an orthostatic vital sign, I don't want to feel my ears burning or whatever it is when y'all know that, yeah, you said that, but you do it. So just wanted to clear the air there.
But it's also at the end of a workup, right? I mean, you've done the whole medical workup for it and come to the point where it's like, well, does the patient need to go into the hospital or can they go home? And for me, it's more of like trial of ambulation and less so like what is the number on the screen. A lot of the times I'll ask the nurse, make sure the patient can walk, right? Because if you can't walk, then I have a hard time sending someone home. But if you can get up and you walk and you feel better, then great. We can probably get you home as long as everything else looks okay.
Said perfectly. I can't, I'm not, that's 9, not 11.
Right.
It's, no, you're unsteady on your feet and you live alone and you've got a crowded, cluttered house and you're going to show up 6 hours later in my shift with the same EMS crew with a broken hip. I don't want to be responsible for that either. So it really is much more a trial of ambulation. Can you do your activities of daily living or not, as opposed to me checking a specific vital sign. I would agree with that 1,000%. So let's wrap it up. Stop checking orthostatic vital signs at MCHD, period, the end. Hopefully, if you have questions or concerns there, reach out to Dr. DePasquale, Chief Smith, and I directly. There's not a protocol for this. We don't train on it. Let's keep our patients safe and let's not give them false security. Let's not give ourselves false sense of security. Let's get the patient to the hospital where we can do a full workup. If you've got syncope or pre-syncope or palpitations or any of those things, we need to know electrolytes. We need to know renal function. We need to know hemoglobin, lots of other things. Premature closure is a real risk. If a third of patients over 70 are orthostatic positive at baseline, what's that tell us? How do we know anything about arrhythmia, medical history, medications, electrolytes, all of those things that need to be sorted through? Sometimes taking the hospital to the patient in the field can be dangerous if you don't have the diagnostics to go with it. So, as always, thank you both for joining us. Hopefully this is a quick hitter that hopefully doesn't make too many people angry, but gives some clarification. If you're an orthostatic vital sign lover out there and you want to throw rotten eggs or rotten tomatoes, please just reach out with questions.
If it raises their blood pressure, hopefully we can get it back down. So.
There we go. Yes.
When they stand up.
Yeah.
For the non-MCHD listeners out there, if you have questions, ideas, please shoot us an email, podcast at mchd-tx.org. We like comments and feedback from our listeners. Wherever you listen or wherever you watch, YouTube, whatever podcast platform you listen on, please subscribe, like, Send us comments. I finally figured out how to respond to comments on Spotify, so I responded to a bunch of old ones this last week. I apologize. I didn't know how to do it until a couple of days ago. So, as always, thank you all for listening. We'll be back with another episode soon.